એક્સપર્ટ અને પછી પ્રેઝન્ટર એને જ ઇન્ટ્રોડ્યુસ કરી દઈએ.
એટલે એક્સપર્ટમાં અર્ચના બેન નામ છે ને?
યસ 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 યસ
ને પ્રેઝન્ટરમાં પ્રત્યુષ ગુપ્તા.
યસ 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 યસ.
ઓકે.
Okay. Yes, Rupsa, please.
Okay, sir. So with all your concern, I'm starting the session. So good afternoon and a warm welcome to all the dignitaries present here. Myself Rupsha from ClearNet, assigned as a station assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by National Neonatology Forum, Gujarat, and the topic of today's session is case presentation, management of preterm sepsis, respiratory distress, and neonatal jaundice. So let's begin today's session, for which I would like to hand over this session to Dr. Kunal, sir. Over to you, sir. Please proceed with your talk.
Thank you, Rupsa and ClearNet. So today we are continuing with our neonatal Pathshala series. And today with us we are going to present a case presentation on the management of preterm respiratory distress with neonatal jaundice and sepsis, which is a common scenario which we see in our day-to-day practice. So we have Dr. Pratyush with us, and as an expert, Dr. Archana. I welcome you both to this session, and to moderate this session we have Dr. Krunal Shah from Vapi. Thank you, Krunal, for moderating this session, and I hand it over to you.
Thank you so much, Kunal bhai. To continue with the neonatal Pathshala, we have a very esteemed expert for the today's session is Dr. Archana Rai. She is a DM neonatologist from Madras Medical College, and we will have a common scenario which is day to day in our practice. We see a preterm with sepsis, with respiratory distress, neonatal jaundice, and the case will be presented by Dr. Pratyush Gupta. So without wasting much time, we'll start the session so we can have much more discussions, and then we can have the closing remarks. Thank you so much. We'll hand over to start with Dr. Pratyush Gupta.
Thank you, sir. Good afternoon, everyone.
Yeah, Pratyush, you can share your screen now.
Okay. Is this being shared to everyone?
Yeah, we can see you. You can start with the first slide, no problem.
Okay, sir.
Pratyush, you need to share your screen again.
Okay, just okay. Am I visible?
Yeah, now visible, yes.
So beginning with the case presentation, and the informant was a mother, Mrs. Sidha bin Parmar, and I'm presenting a case of a day of 14-day-old male child who was born on 3rd of October 2024 at around 2:55 p.m. at our hospital, and the patient belongs to upper lower socioeconomic status, and the chief complaint of the patient was increased work of breathing soon after birth. Beginning from the maternal history, mother was 30 years old with a pre-pregnancy weight of 35 kilograms, and at the time of the delivery, she was weighing 43 kilograms, weight gain of around 8 kilograms during the course of pregnancy. The mother's height was 152 centimeter. It was a non-consanguineous marriage. Mother was a homemaker, and she had no history of any heart disease, asthma, tuberculosis, or diabetes mellitus. Moving on to obstetric history, she was the fourth gravida, and there were 2 live births and 2 abortions. The first child was 9-year-old male child, and the current child is the second live birth of the for the mother. There are history of two spontaneous abortions. The first was at 3 months of amenorrhea. It was 7 years ago. And the second abortion was at 2 months of amenorrhea 3 years ago. The first trimester history, it was a booked and
Excuse
registered
me,
case.
sir. Can I just interrupt and then can ask questions, right? No, sir?
Yeah. Yes, sir. Yes, ma'am. You can ask questions in between also.
Yes. So can we go to the first slide? So whenever we are presenting any case, we should hide the identity of the patient, right? So we should not put any baby's name or mother's name. We should write XYZ, right? So this is one of the first steps. Okay. The next slide. Okay, next. So here you have written that mother's pre-pregnancy weight was 35 kg, right? And the weight before delivery is 43 kgs. And so how you will interpret this pre-pregnancy weight and weight before delivery?
Retrospectively seeing, it was a preterm delivery, and that if I would say this was a delivery at around 7 months of amenorrhea. So that I could say that it was an adequate weight gain during the course.
Okay, what is the expected? Usually, if the baby is delivered at term,
it's around 12 kilograms at term delivery.
okay, how this weight gain usually happens?
It's the maximum weight gain is in the last trimester of pregnancy. It's around 6 to 7 kilograms.
Okay, in the first trimester?
2 kilograms.
Usually it will not be much in the first trimester because mother will be having some hyperemesis or vomiting issues, nausea issues, and usually the first month only the embryo is getting developed. So first 3 months there will be very little weight gain. So 1 kg to 2 kgs weight gain is there usually in the first trimester. Okay, in the next 2 trimesters there will be 5 to 6 kgs weight gain will be there. Okay, but since still the pre-pregnancy weight is very less, is it acceptable? Can it will lead to preterm birth?
Yeah, it's a risk factor for a preterm birth.
Okay.
It with a low BMI, and it is always a risk factor for preterm deliveries.
Yeah, so you should also write about the BMI. You know? So it will predispose to preterm birth. And why you have specifically wrote this history, no history of heart disease, asthma, tuberculosis, diabetes mellitus, is it going to have any correlation with our this case?
Diabetes mellitus, if it would sometimes lead to early deliveries. Asthma is one of the risk factors for transient tachypnea of newborn.
How diabetes mellitus in mother will lead to early delivery preterm birth? Is it just what you ask for, gestational or over diabetes mellitus? Is there any difference between
It's
gestational
usually
and over
the gestational diabetes mellitus, which would a diabetic mellitus mother could present with congenital anomalies in the fetus, and preterm deliveries, it is quite possible, along with surfactant deficiency and respiratory distress syndrome in a mother with diabetes mellitus.
And why tuberculosis only? Is tuberculosis going to give birth, cause preterm birth, or any other infections in the mother will cause preterm birth?
Preterm birth is usually precipitated if the mother has a history of congenital infections like syphilis, congenital rubella, and other infections like chorioamnionitis and high-grade fever. Apart from this, these are the risk factors. These could be the risk factors for preterm delivery.
So tuberculosis.
Tuberculosis is the risk factor for the baby. It is one of the risk factors we
If you
should
want
consider.
to write, you should write about what are the common risk factors for preterm birth. Okay, so tuberculosis. Okay, it's like India it is there, but usually we doesn't ask tuberculosis in case of preterm delivery, right? We should ask mother has fever or pain abdomen or UTI infections during the antenatal period.
Okay.
Next. Okay, so mother is gravida 4 live births, including this one, no? What we are going to discuss, and 2 issues. So this is spontaneous. The first live birth is now 9 years old male. Any antenatal, any postnatal histories you want to ask in this first live issues? Is it going to be helpful in this case or not? If yes, why? And if not, why?
A history of recurrent abortions in case of certain congenital infections we need to screen for. And secondly, if the cervix doesn't usually get mature, and that could be one of the cause for early recurrent abortions in the previous pregnancies.
Okay, first you told like congenital infection. Another is your cervical incompetence. Okay. And first live birth was what kind of delivery? Any idea?
It was a normal vaginal delivery.
No, was it preterm or full term?
It was a full term. It was a full term baby, and the child is healthy, and they did cry immediately after birth. Then.
So why this question has been asked to you? Any idea? If the live issue was preterm or term, is it has got any relevance with this case?
Would be, and mother could have suffered from any new infection, or she would have a certain weight loss, excessive weight loss, considering she's right now 35 kilogram, and that could have, she would have lost. She would not have gained weight, or she would not have got healthy during the further pregnancies.
No, actually, if the mother is having one issue as a preterm, there are chances that another issue she can deliver a preterm baby. There are 15 to 20% chances. So we should always ask this history that the previous live issue was preterm or term baby, right?
Okay. Okay, ma'am.
Yeah. Next.
Now, the first trimester history, it was a booked and registered case, and there were 2 antenatal care visits during the first trimester. There was no history of hypertension, or diabetes, fever with rash or lymphadenopathy, or excessive vomiting, burning micturition, or bleeding per vaginum during the first trimester. No history of medications or drugs, except the folic acid supplementation was started during the first trimester when she visited. No history of radiation or alcohol or tobacco consumption or smoking history. Dating scan was done. USG scan was done when she first visited the hospital.
Okay, so in this first trimester, she has underwent 2 antenatal visits. Overall, during pregnancy, how many antenatal visits is advisable?
It's 12 antenatal care visits.
Is it 12 according to Government of India, WHO, any specific reference regarding that 12? Why 12 only? Why not 10? Why not 8? Why not 6? Why not 4?
In the last trimester, it is just before delivery, it is once a week. That is 4 antenatal care visits beginning from 36 weeks. And before that,
Your voice is breaking. I think your network is having some issues with that. Okay, so usually at least 8 antenatal visits has been advised as per the WHO. Okay, so in the first trimester, she should underwent at least 1 antenatal visit, that is within 12 weeks of within the first trimester, within 12 weeks, she should register herself. Yeah. So in this, you have written that she was not having any medical history, fever, rash, burning, micturition, excessive vomiting, bleeding per vagina. Okay. When this folic acid supplementation is usually advised in mothers?
In our country, it is usually started at when the pregnancy is usually first diagnosed as, but usually it should be started at least 1 month prior to pregnancy.
How many weeks prior to? And what is the dose advised?
0.4 milligram is the ideal dose to start with, but if there are the neurological previous pregnancies have suffered some neurological conditions, then it should be a 4 milligram dose. and it should be started at least 4 weeks prior to pregnancy.
3 weeks prior, 3 months prior, and 1 month
3
post.
Okay.
So in that, it's not neurological issues, it's specifically neural tube defect.
Neural tube defects, ma'am.
Yeah. So if mother has severe issues with neural tube defect, it should be 4 mg. But do we have any 4 mg tablets?
No, so we give the 5 mg tablets in our country.
Yeah. So you routinely we advise 5 mg tablets. Okay. So no history of medications, alcohol, tobacco, and smoking. How alcohol, smoking, tobacco is going to affect our this case?
Tobacco consumption also is a risk factor for a preterm delivery. Alcohol leads to fetal alcohol syndrome, and radiation exposure in the very first trimester it usually leads to congenital malformations in the pregnancy.
And also leads to low birth weight. Smoking leads to preterm delivery and low birth weight babies. Okay. In dating scan, you are going to do. So you will be assigning mother some USG EDD, right?
Yes, ma'am.
So when you are when your baby is being delivered, mother is not which gestation you are going to take as appropriate for the baby. Like you are going to take LMP for deciding the baby's gestational age, or first trimester EDD, or NBS, newborn scoring, something like that you would have heard. So which out of this three, which you will be using to assign gestation age to your baby?
The first trimester scan is usually the best if it has been done. Otherwise, we do rely on the last menstrual period. The first scan, if done within 7 to 14 days of when the pregnancy is diagnosed, is considered the best with the minimal deviation from the expected date of delivery.
Okay, and how her pregnancy was confirmed?
Pregnancy was confirmed by urine pregnancy test when the patient visited to us, when the patient visited our hospital with the for the visit.
Okay. Okay. Next.
Second trimester pregnancy, fetal movements were perceived at approximately 5th month of gestation. She again had 2 visits during this period. Iron and calcium supplementations were started. There is no history of headache, blurring of vision, giddiness, swelling of lower limbs, or fever with rash even during this trimester. No history of burning micturition, increased urinary frequency, or bleeding per vaginum, or any pain in the abdomen. No history of hypertension. RBS was checked during this visit, which was normal. USG scans were again done in the second trimester, which were normal. A tetanus toxoid 2 doses 4 weeks apart were taken.
Okay, so in this you have told this mother is gravida 4 and the fetal movements were perceived at 5th month of gestation. So is there any differences there that she between the fetal movement perception quickening, that what we say is between the first issue and the second issue and the next subsequent issues? Is there any difference, or is it always around?
In the very first pregnancy, is usually, as perceived by the mother, it is usually late as told to the doctor. But in the subsequent pregnancies, the mother just conveys at the earliest.
Okay, and next third point you have written, mother has received iron and calcium supplements. So when it is started and what is the dose we usually start mothers?
Iron, these supplements are started beginning from the second trimester, as the first trimester is a high risk of has the usually can have hyperemesis gravidarum, and iron further being an irritant can aggravate the emesis. Iron is usually given in the dose of 400 milligram per day.
Hello?
Hello.
Yeah. So what is the dose of iron?
It's 4 milligram per day.
4 milligram is your folic acid you told, no? 5 mg tablet we have, so we give 5 mg of folic acid, right?
100 milligram elemental iron is usually given during the pregnancy.
It's, as per the government of India, it is usually given as 60 mg of elemental iron with 500 microgram of folic acid, right? And it has to be at least given for 180 days in the antenatal period. Better to give from the second trimester, from the 4th month, and to be continued post delivery till 6 months postpartum. Okay. And what is the dose of calcium?
500 milligram tablets.
OD, BD, TDS?
BD, given in a BD dose.
Okay. Then you have written all this. What's the swelling of lower limb is going to tell you? Blurring of vision, headache, swelling of lower limb.
It's usually a case if a patient has hypertension during the early pregnancy, it could lead to these symptoms: headache, blurring of vision, swelling of lower limbs, or
Okay. So hypertension, gestational hypertension. If not treated, what it will lead to?
it could lead to eclampsia and early termination of pregnancy.
So in between comes a preeclampsia. So
Okay,
hypertension is not going to have blurring of vision and all. Preeclampsia and impending eclampsia is going to have blurring of vision. Okay, next is your burning maturation. Why burning maturation?
UTI is the risk factor for premature rupture of infection and early preterm delivery.
Okay, and okay, so pain abdomen. Why pain abdomen?
Pain abdomen, one of the chorioamnionitis. It's one of the signs of the chorioamnionitis.
So mother is going to complain of pain abdomen.
Yep. Don't know.
So what you know about the true labor pain and false labor pain?
True. True labor pain, false labor pain usually would subside after medication and usually could present in the second trimester.
Which medication you are going to subside that pain? So chorioamnionitis doesn't usually present with pain abdomen. It usually presents with fever.
Okay.
And if it is pain abdomen, it will be very gross then.
Okay.
So we have to rule out if like mother already have two spontaneous abortion, mother is prone for preterm delivery. So we should rule out if it is true labor pain or false labor pain.
Okay, ma'am.
You have written RBS checked and was normal. When usually the RBS should be checked in during pregnancy.
It should be ideally be checked during the second trimester of the pregnancy, as GDM usually won't be a risk factor for congenital malformations, but if the mother is having high sugar values during even the first trimester, then it is a risk. It could lead to anomalies.
So usually RBS are checked during the first. All antenatal mothers should have their fasting and post-parental sugars checked in the first trimester, and especially if they're having any risk factors like the previous history of gestational diabetes was there in the mother, or family history of diabetes is there, or like your BMI is more than 30. So that mother should definitely undergo this RBS monitoring. And irrespective of that, all antenatal mothers should have their second RBS at least mandatorily to be checked by 28 weeks of gestation. Okay. So in second trimester, usually we don't do, and we don't do by the mother is high risk. What we usually do?
Ma'am did not hear you. It was
Usually we don't check RBS. We check fasting and post-parental sugars, right?
okay,
It's
ma'am.
not RBS. It's not random blood sugar. It's fasting or post-parental.
Okay.
So if we are going to check mothers with having risk factors, what test you are going to do?
It should be oral glucose tolerance test
Yes.
or HbA1c values.
So, HbA1c values we check in mothers having your glucose tolerance test abnormal. Fine. If the mother is having gestational diabetes mellitus or over diabetes mellitus, we are going to check HbA1c. So in gestational diabetes mellitus, in glucose tolerance test, how much glucose is usually given for glucose tolerance test checking?
75 gram of glucose powder is given, ma'am.
Okay.
Or if we don't have, then we can't measure, then it could be 100 grams.
As per the GOI guidelines, it is 75. Okay. Okay. Then you have written USG scan in the second trimester, which was normal. What this scan is known as?
Anomaly scan.
Okay. So when it is usually done, what weeks of gestation?
16 to 20 weeks of pregnancy.
What is the another name of this scan? Something known as TIFA. Have you ever heard of TIFA scans? Okay, so anomaly scans were normal in this baby. Another is mother has received 2 doses of tetanus toxoid. Is tetanus toxoid TT is given or anything else is now given?
TD is given as per the government protocols right now.
In government, they are giving TT or TD?
TD.
Yeah, so you have written TT, right?
Yeah.
You should have written TD.
Okay.
Which is better, TD is better or TDAP is better?
TD would be better. TDAP could lead to high-grade fever. No, sorry.
No. TDAP is much better because it will, newborns also, they can be having atypical infections. So it will prevent from pertussis in the newborn period. Okay, that pertussis component will be helpful in the newborns. Okay, next.
In third trimester, before delivery, she had a total of 3 visits, and fetal movements were well perceived during this time. No history of bleeding per vaginum or pain in abdomen or burning maturation. No foul smelling discharge. As said, no history of abnormal sugar values or hypertension had been documented. The supplements were continued, scans were repeated, and total weight gain, which was achieved, was 8 kilograms just before delivery.
So third trimester scans, what they are usually known as?
Weight growth scan.
Growth scans. So the scans were reported to be normal or anything abnormality was detected in that?
They were told to be normal for that pregnancy.
Okay, so in growth scans, normal. Fine. Next.
Labor history. Mother was admitted on 28th of September with a leaking PV for 5 days. She was admitted on 28th of September on the very first day of leaking, when the leak started. And she had been at our hospital for the next 5 daes. 2 doses of betamethasone were administered. Mother had, on investigations, mild anemia, hemoglobin of 9.2. Blood group was documented to be AB positive, and her serology was negative. At the time of delivery, the amniotic fluid was clear and it was non-foul smelling. There was no history of fever in the past 2 weeks. Delivery call was attended by a doctor, and a male baby weighing 1.2 kilogram was delivered via induced vaginal delivery in vertex presentation on 3rd of October. The baby cried immediately after birth.
Okay, wait. So mother had his history of leaking PV for 5 days. What is the significance of this leaking PV for 5 days?
Leaking PV for 5 days could result has a high risk for baby getting infection, and that could is a risk factor for the preterm delivery. And the baby should then get prophylactic. I started with antibiotics, considering it to be a high risk.
So what? How much? Any duration is important in leaking PV, or any duration will be significant for leaking PV?
The more than 24 hours is usually considered significant before delivery.
This gestation age at delivery was
31 weeks.
okay, 31 weeks. So 31 weeks. So any preterm baby in any preterm delivery, any hours of leaking PV is significant. We don't know. It can be high rupture of membrane also. HRO what it tell us. So in leaking PV, what all we can do to prevent infection in this mother? We don't know baby has fetus has catch infection or not.
We usually start the mothers immediately on antibiotics, considering it to be a high risk, and we prefer to delay the pregnancy as long as possible with the toccolysis, and cervical cerclage could be done to prevent the if it is not cervical cerclage could be used for prevention of early delivery. And we should give time for betamethasone if that could be 2 doses could be given. Steroid can be given.
So first you told steroids when the mother is having leaking PV. So you are giving steroids. You have written 2 doses of betamethasone was given. So which preparation of betamethasone was given to the mother? Do you have any idea what preparation is present in India and in the outside India?
No, ma'am.
No. So okay. Why betamethasone is given? Why not another steroids which are routinely given to the antenatal mothers?
It is dexamethasone.
Okay.
It's
So which is better?
Betamethasone is currently being advised right now.
Advised right now where in
But
India?
it's not quite commonly available in our country, right?
Okay, what is the dose of betamethasone?
12 mg given 12 hours apart.
12 mg, 12 hours apart. So 2 doses, 12 mg, 12 hours. And Dexa?
Dexa is 6 mg.
Interval? How many doses?
Total of 4 doses it is given.
So 6 mg, 4 doses, interval?
Every 6 hours. Every 12 hours it is given.
So the Dexa dose is 6 mg, 12 hourly, 4 doses we give, and Betnasol is 2
it
doses.
Is 24 hourly.
So the Betnasol dose, what we are having here in India, is not what are usually being practiced in outside world, right? So all the literature is from the other formulation of Betnasol. It contains both 2 salts of Betnasol, which has acetate and phosphate. So acetate is longer acting and phosphate is faster acting. What preparation we are having in India is phosphate only, that is faster acting. But what we want is we should have a steady state concentration in the mother, right? We doesn't want just there will be spike and then there will be low levels in the mother. We want to maintain a level in the mother serum levels, right? So that's why preparations in India, what is available is betamethasone phosphate. So it is not going to help much in our case, right? So what we usually give and what the government of India advice is we should give dexamethasone. Why? Because we are not having our long-acting component. Yeah, we don't have a long-acting component in Betnasol. Secondly, it is easily available, that dexamethasone, and if we are procuring Betnasol from outside, that will be having cost issues. And both have been shown to have equal efficacy and safety, right? So that's why dexamethasone is advisable as per the GOI. Okay, GOI is Government of India. Okay. So first thing you told, mother is having leaking PV, you are giving steroids. What else you can do? Your baby is 31 weeks old. What is the cutoff for giving antenatal steroids in preterm babies, preterm mothers?
It is 34 weeks. It is usually 24 to 34 weeks.
Okay. So when this mother has received this steroid, what is the interval last dose?
It was she was given the first dose when she first visited on 28th of September.
Okay, and another. Okay, so it was within 7 days from the delivery, right? The last dose was mother has completed her antenatal steroids within 7 days of delivery. Fine.
Yes.
Another
Yes.
what you can do when your baby is preterm when the mother is having preterm labor or having impending preterm birth, then what else you can do? But mother is having leaking PV also. There are chances of infection. Is it advisable to give steroids, antenatal steroids to this mother?
It is if there is a high suspicion, high grade fever and likely signs of chorioamnionitis, then only that's a contraindication for steroid administration. Otherwise, considering the considering the benefit to risk ratio, we usually give steroids in such pregnancies.
So when you will tell that it is chorioamnionitis?
It could be a foul smelling liquor or a fever, a high grade fever, and considering leukocyte count to be more than 15,000 in the mothers. These are if you or a pus discharge per vaginum or foul smelling liquor.
Okay. Okay, fine. So chorioamnionitis we are not going to give. Otherwise, in all the cases, you are going to give mother antenatal steroids. What else you are going to give to the mother? What all is advisable to give the mother who is having preterm birth?
Magnesium sulfate injection is usually it helps in neuroprotection of the fetus, and antibiotics considering a high risk. Hello.
Archana ma'am, you have got muted.
So what is the dose of Maxilf? Am I audible now?
Yes, ma'am.
Yeah, so Maxilf you told me in less than in this preterm birth you are going to give mother Maxilf. How is it going to help the mother and the baby, and what is the dose if you have any idea?
Loading dose is usually 4 grams given as an infusion, and I don't remember the maintenance dose.
Okay, 4 gram over 15 minutes, followed by 1 gram per hour over the next 24 hours, or delivery, whichever is earlier. Fine. Previous slide. So your baby was born 1.2 kg Apgars.
Apgar was 7/10 at the 1 minute of life.
7/10. Why the mother was induced?
Mother was induced considering she had developed as per the OBG guys she had developed significant loss, and that was considered a risk factor for further continuation of pregnancy, and steroid had been given.
So any scans were done prior to delivery? What was the AFI level at that time? Any idea?
No, ma'am. No.
Fine. Fine, we will proceed further. Otherwise, we'll be stuck here only. Okay, next.
Postnatal history, vitamin K supplementation was given then and there.
Okay, one second. Just you told at that time when the mother is having leaking PV, you will do cervical circulage, I think you told.
It is not done considering it further is a high risk for further transmission of infection. It is usually considered in cervical incompetency.
So at 31 weeks, you are not going to do cerclage in mother first of all. It is usually done at around 24 to 25 weeks of gestation. And when there is frank infection, and leaking PV, Rupture of membranes, it is not usually done. Okay. Next.
At the time of the birth, 1 milligram of vitamin K was administered to the baby, and the baby was shifted to an ICU as the baby was having respiratory distress.
So 1 second, we will pause here. Firstly, this is preterm delivery, 31 weeks, 1.2 kg male born by vaginal delivery, right? So
Yes,
what the extra stuff you are going to do in the neonatal resuscitation program as compared to a term delivery?
If the baby has respiratory distress just at the time of the delivery, if it is possible, then we should start early CPAP in the delivery room, and prevent the maximum care should be taken to prevent hypothermia in such neonates.
How do you prevent hypothermia in such neonates?
Ma'am?
How do you prevent hypothermia in such neonates?
Taking in a clean, just after the delivery, we should take in a clean, dry, warm sheet of cloth, and need to do whatever needs, resuscitation or anything needs to be done under the radiant warmer. And
this is usually you do in term delivery, right? What extra in less than 32, this baby is less than 32 weeks gestation, right? So what extra you are going to do to prevent hypothermia in this baby? Because everything, whatever you do in your delivery room has got implications in your NICU management. Even your hypothermia, the admission temperature in the baby has got lots of complications. So we have to prevent hypothermia at all costs in the delivery room. Have you heard about polythene bags used in less than 32 weeks?
Yes, ma'am.
Okay, when the baby is delivered, are you going to wipe the baby off? You will dry the baby usually in term delivery. Are you
Term
going
baby, but no, ma'am, we don't usually, we don't do it in the very low birth weight babies.
So the person attending the delivery has to know all these minute details. First of all, the delivery room temperature, how much it should be?
It should be around 25 to 28 degrees Celsius.
Okay, and the radiant warmer, you told you will have radiant warmer. So how you are going to warm radiant warmer? Which mode you are going to keep in the radiant warmer? There are two modes, no? Manual mode and
manual.
Yeah. So which mode you are going to start with?
It should be manual at the very beginning.
Okay. And how much heater output? When you go and attend the delivery, you attend delivery, right? I assume that you are attending deliveries.
Yes, ma'am.
Yeah. So you are going to attend delivery. So what you are going to do in delivery room?
Maximum heater output should be checked.
So what is the maximum heater output? It is 100%. No, you should have 100% output, right? And it will take around 15 to 20 minutes. So it should be started before the delivery has happened. Okay.
Okay, ma'am.
So it should be on for at least 20 minutes. Then you will take the baby in your polythene bag or plastic wrap, whatever is there. You are not going to take your baby in your warm linen.
Okay,
you will take the baby in your plastic bag. Anything else you can do during delivery? Something known as something related to preterm baby, right? 31 weeks. Is it going to have any implications, the cord management?
Delayed cord clamping should be done in such babies. If it is more than 28 weeks, we should never prefer for early cord clamp if the baby has died immediately after birth. Only in less than 28 weeks of pregnancy, we could go for early cord clamping. Else, if there is a high risk, then we could go in such babies for cord milking.
In less than 28 weeks.
Yes,
hello, in less than 28
yes,
weeks, cord milking, right?
Yes, ma'am.
There's some confusion. See, in less than 28 weeks, we should never do cord milking because it is shown to cause IVH. you can do cord milking in more than 28-weeker babies. If you want to do cord management in less than 28 weeks baby, it should always be delayed cord clamping, but the baby should be vigorous, right? And the breathing efforts should be good. In more than 28 weeks, you can do delayed cord clamping or cord milking, but delayed cord clamping is much more physiological as compared to umbilical cord milking. Fine. So how much delay you are going to do in cord clamping?
It should be at minimum of 30 seconds and can be done for approx 1 minute.
How is it going to help in this baby? Your baby is preterm, right? Having respiratory distress also. So
it prevents neonatal anemia.
And your topic is respiratory distress, sepsis, preterm, right? So how is it going? And NNHB also, I think. So on respiratory distress, what delayed cord clamping is going to have implication on jaundice, what implication it is going to have, and what implication it is going to have on a preterm per se.
In cases of jaundice, it is told that delayed cord clamping can sometimes have neonatal hyper more than normal of increased bilirubin. In preterm delivery, it could present as sometimes as polycythemia, and then it could lead to early jaundice. In preterm babies usually don't have iron source, and that could precipitate significant anemia if it is not done usually.
What else for preterm baby? Something related to hemodynamics?
Lesser chance of development of shock in such patients because of adequate volume they would be having.
Yes, and what implications on IVH?
It would decrease the chance of IVH.
And what implications on RDS, respiratory distress?
More of circulating blood volume. If more of oxygen carrying capacity, then it would could lead to early resolution. There would be less severe disease manifestation.
Not exactly like that. Actually, it increases your preload because it causes your lungs to open up. So your preload for the left ventricle is your lungs, right? So it is going to improve your preload to the left ventricle, and it is going to improve your left ventricular output. So in this way, it is going to help in the respiratory distress. So the delayed cord clamping has got implication in different stages or different diseases in preterm babies. Okay, fine. So 1 mg IM vitamin K you have given. Fine. What else you have done in the delivery room? You have taken the baby, you have took in the plastic bag, you have brought to the radiant warmer. You have given vitamin K also. Anything else you can do in the delivery room? Baby is having distress.
Early CPAP administration is considered the best, but we don't have
CPAP. Okay. So anything you know about the delivery room CPAP? What FiO2 you will use?
In a preterm delivery, such patients, 30% FiO2 at max, 30% FiO2 need to be started with.
How early CPAP is going to help in respiratory distress?
It would prevent the collapse or atelectasis of the lung.
Okay, by maintaining your FRC, right? Okay, yes. Fine. Next.
The gestational age assessment, the last menstrual period was 20th of February 2024, and expected date of delivery was 7th December. The baby was delivered at 31 weeks of pregnancy. With the birth weight for gestational age, when plotted, the child did fall in the small for gestational age group, the 3rd to 10th centile. Length was 40 centimeter, 10th to 50th centile, and head circumference was 29 centimeters, 50th to 90th centile. With the ponderal index being 1.82, falling in asymmetrical IUGR.
Okay. Next, we will go fast. We have got best time remaining. Next, CPAP support.
CPAP support and IV fluids were started when the child was shifted to an ICU, and it was given for a duration of 15 hours. Feeds were started at 3 hours of life via orogastric tube and gradually increased. Full feeds were reached on day of life 3. Antibiotics were started in view of risk of early onset sepsis and were continued for a duration of 7 days. Baby developed yellowish discoloration of skin during the stay, and phototherapy was started on second day of life and continued for a duration of 48 hours.
Okay, 1 second, we will pause here. So you told that baby was started on CPAP. Okay, what? Baby didn't require any surfactant, right?
No, ma'am.
Weaned off in 15 hours of life. This baby was SGA.
Yes.
Any Doppler changes were there in scans, antenatal scans? It was not
No,
IUG.
ma'am.
Baby was
No.
SGA only. Okay. Okay. You started feeds and re-feeds on day 3 of life, phototherapy, risk of sepsis. Okay, fine. Any sepsis marker were positive?
No, septic markers were not positive in this child.
7 days of antibiotics, why it were given? Sepsis.
Usually it is to be 5 days of antibiotic if the septic strain is negative.
Okay, fine. Which charts you use for for making knowing the phototherapy range and exchange range in preterm babies?
The new WHO nomograms, which have been in circulation since 2022.
Which one?
WHO nomograms for with neurological risk factors.
WHO has got nomograms for phototherapy? That 2022 is AAP guidelines, right?
AAP nomograms, okay.
Yeah. So that AAP guidelines is for which gestation age?
It is more than it considering the along with the neurological risk factors and without neurological risk factors, and more than 37 weeks of gestational age. 35 weeks of gestational age. 35 weeks.
But your baby is 31 weeks. Did you use the same nomograms?
No, NICE guidelines we did use.
So you tell according to your cases, right? So you use NICE guidelines. Fine. Okay, next.
Baby passed urine and stool during the first 5 to 6 hours of life. Presently, baby is passing urine approximately 5 times and stool around 4 to 5 times per day. Baby is currently allowed non-nutritive sucking and taking spoon feeds well. EBM 45 with preterm formula is...
How much corrected gestation age today is?
It is 33 weeks.
Okay. So baby is taking spoon feeds. Okay. Did you start anything else in this baby? Your baby was less than 32 weeks. Postnatally, you gave CPAP. You started on partial parental nutrition, right? It was not total parental nutrition, right? And then you started baby on feeds and antibiotics. Anything else you could have done in this baby? Though your baby did quite well, but less than 32 weeks, is it advisable to give something? These babies are prone for something known as apneas.
Caffeine citrate is usually given if the baby presents with apnea. It should not be given prophylactically. It should be given only when weaning off or in less than 28 weeks of pregnancy.
No, actually it is advisable to give in all less than 32 weeks of babies. It's not like when the baby develops apnea. Okay, fine. EBM 45 with preterm formula is given by a spoon every 2 hours. So this baby is on how much ml per kg per day of feeds?
The baby is on 180 ml per kg per day of feed right now.
Well, 6 hours per day. And this current weight for babies today is?
1.28 kilogram. The birth weight was 1.21 kilograms.
Okay, so a baby has reached your birth weight. When you have started fortifying babies?
The The feed was started with fortification on when the child reached the full feeds. It usually should be started. It is usually started as 100 ml per kg per day of feed when the of feed is achieved.
What in your unit? When you start usually fortification?
We usually start fortification with the preterm formula when we are just about to omit the IV fluids. When 70 to 60 to 70 percentage of feeds is achieved, we do usually start.
So how much it is usually in ml per kg per day? So 70, 60, 70 to 80% is 100 ml only, no? If full feeds are
Yes, ma'am.
150. So it supplementation. Okay, you have got your calories, proteins chart with you. How much calcium, phosphorus, everything is going with the baby.
Calcium supplementation. Sorry, ma'am.
You are fortifying babies with preterm formula. You're giving calcium. How much calcium in total is going to the baby?
We are giving 150 mg per kg of this calcium supplement to this baby.
In total or only syrup?
In total on a daily basis.
Okay. And multivitamins drops. And what else you will be giving in this baby? This baby is 14 days of life, right? So what else you need to give to this baby?
Iron supplementation could soon be started.
When should it be started?
After completion of 42 weeks of life.
Okay, so your baby is 2 weeks of age now. So you will be fortifying the with iron from now onwards?
Yes, ma'am.
This KMC, when you start KMC in your unit?
KMC, we usually start in our unit. We start when the child is of CPAP, then we and is more of a stable. Then we start with the KMC. After 3 days, considering the child won't be having a high risk.
Okay. Okay. Next.
Birth dose has been given. Still, the child is admitted. We have given OPV and BCG.
Okay.
General physical examination. The child was examined and the baby was alert and responsive with normal cry. Skin color was pink and there were no signs of peripheral or central cyanosis. Vitals, it was 37.1 degrees Celsius under radiant warmer. Heart rate was 132 beats per minute. Respiratory rate was 42 breaths per minute with a capillary ripple time of around 2 seconds. Pulse volume of...
baby. Okay, we can skip this part. Baby is vitally stable, right?
Yes, ma'am.
Okay. Anthropometry wise, your baby is less than percentile and its circumference is 30 between 10 to 50. So what does it tell you?
Around though he has the birth, the baby has crossed the birth weight, but considering growth charts, the weight gain could have been more on this day of life.
Okay, next.
Headway is normal with a normal spontaneal size of 1.8 to 1.5 centimeter, diamond in shape, non-bulging. No evidence of any scalp swelling with the normal face and normal eyes. The ears being normal and oral cavity and contents were normal. Umbilical cord and umbilicus central, stump healing, no discharge. Genitals, penis normal, bilateral testis palpable in a scrotal sac. The back end is fine.
Okay, next. Everything is not respiratory system. Next. Okay, next. Reflexes. What all reflexes you are going to see in your baby?
Prematurely developed sucking reflex is developed. Palmar and plantar grafts is present. Asymmetrical to symmetrical morose is usually present during this with 33 weeks of gestational age.
Asymmetrical and symmetrical both will be present.
Symmetrical, complete and symmetrical morose reflex is present. It could be at this age asymmetrical, incomplete morose reflex at this age.
Why the morose will be asymmetrical in this age?
It usually develops by 34 weeks of gestation. It is symmetrical in my baby, and it needs to be symmetrical. It could only be asymmetrical if the child has paralysis or traumatic delivery, trauma at the time of delivery.
Okay, next.
Bilateral pupils were reactive to light. Third, fourth, and sixth nerve eyes move equally in all directions of gaze. The fifth nerve bilateral conjunctival reflex was present.
Okay.
No facial.
Fine. Next, cranial nerve examination is normal. Final diagnosis is?
It was a preterm, 31 weeks, 1.20 kilogram, small for gestational age baby, with the PI being 1.8, male baby, delivered vaginally with a history of leaking PV for 5 days, and CIAB with respiratory distress, probably due to transient tachypnea of newborn, along with the neonatal hyperbilirubinemia.
Okay. So, what is the next plan for this baby? You have immunized the baby. What is the next plan?
Ma'am, next.
Plan for this baby. How you are going to plan discharge in this baby?
Non-nutritive sucking has been started. We would wait for around 1.4 kilograms for this baby to achieve, but we will have started non-nutritive sucking, and we will increase the duration of breastfeeding as a child as early as possible, or by 34 weeks of pregnancy, seeing the condition of the baby.
Okay, so first, one thing more, when you are presenting this kind of cases, when your baby is now in the growing preterm phase, right? So you should always tell about how much calories baby is getting through your feeds and your fortification, how much proteins baby is getting through, because your baby is SGA, right? They need the baby to go into the normal growth pattern, right? So this baby you should always present during your exams also. You have to present in this growing preterm case your calories, how much baby is getting calories on today's date, how much proteins, how much calcium, how much phosphorus, how much sodium, and how much iron. At least this 5-6 stuff are mandatory when you're presenting a growing preterm case, right? So that, because you told 180 ml per kg per day of feeds are going on to the baby, but you don't know how much calorie is going on. The preterm mother babies on exclusively express breastfeed. No other preterm formulas are not there. Only you are fortifying with preterm formulas, right?
Yes, ma'am.
Yeah, so the preterm mothers also, their proteins, calories, everything will gradually decrease as the weeks passes by. So we have to fortify accordingly. We should know how much calories, proteins, calcium mother is having at that weeks of postnatal age. Okay, so firstly you are going to have fortification. You have immunized the baby. What all you are going to do before you are planning the discharge for this baby?
The hearing assessment needs to be done for this baby. Autoacoustic emission, both ears should pass for this. And
what is advisable? What hearing screening should be done? This is your NICU graduate. This is high risk baby, right? Autoacoustic emission, what it is going to pick up?
It will just assess the outer hair cell function. It won't be able to assess the cochlea or the inner ear function or the brainstem pathology. That could quite be missed if we just go with the autoacoustic emissions.
So what you should do ideally in your high risk babies or NICU babies?
Brainstem evoked response audiometry should be ideally be done.
ABR should be done. Okay, so you are going to do hearing test. You have immunized the baby. You are fortifying the baby with iron, calcium, and fortifications, right? What else you are going to do? This is your 31-weeker baby is now 14 days of life. What all are important in this baby? Specifically from the medical legal point of view.
ROP screening can be done at
When you are
but
going to ROP screening in this baby?
at 4 weeks of postnatal age or completed 34 weeks of gestation. 34 weeks of gestational
You are
age.
going
matlab,
to for 34 weeks.
whichever is later, matlab for this.
You should do by 3 to 4 weeks of your
3 to 4
postnatal.
weeks.
Right. Fine. And what else you are going to do when ROP is there? What else you are going to do? ROP,
Depend
immunization.
depending if depending on the severity of the ROP, further plan could be injection bevacizumab injection or laser photocoagulation.
What checklist you are going to have? One is your feeding, right? Proper calories,
Yes.
proteins, irons, calcium, everything has to be gone. Proper weight
Yes.
monitoring has to be done. Second is the immunization, what you told that you have immunized and you will take the next immunization day. Third is your e-hearing screening. Fourth is your ROP. What else? NNS you told.
Yes,
Okay.
ma'am.
One thing you told KMC. Are you not going to continue KMC?
We will be continuing KMC until the 2 kilogram of weight has been achieved or so for
Okay.
better weight gain.
Okay. Okay. Fine. Fine. Nice presentation. Nice answering of the questions. Just need little fine tuning. That's all.
Thank you, ma'am. Thank you, ma'am.
Yeah. Very good.
Yes. Thank you so much, Pratyush. It was an excellent presentation. Thank you, Archana ma'am,
Thank you, sir.
for guiding him. And the questions were very basic also and very informative for them. And it would been a very great learning curve for them so that they can do better in their exams also. Thank you so much.
Thank you, sir.
Yeah. Thank you, Krunal, for excellently moderating the session. Thank you, Pratyush, and thank you, Archana ma'am. Thank you,
Thank you,
ClearNet.
ma'am.
Yeah, thank you, ClearNet, for the seamless experience. Thank you all.
Thanks.
Yeah. Krunal, you have any questions? Or
No, thank you so much. We'll end the session here.
thank you. Yes, Rupsa, we can end this session now. I think everyone can leave now. Yeah. Thank you. Have a good day.